We'll proceed with our next speaker, and that's Dr. Melita Viegas. She's assistant professor in cardiothoracic surgery here at Children's Hospital Pittsburgh, and she's going to be talking about mechanical support in the early stages of univentricular heart palliation. This talk is recorded as Melita is unable to be here today.
Good afternoon, everyone. My name is Melita Viegas. I'm one of the pediatric cardiac surgeons here at Children's Hospital Pittsburgh, as well as the director of pediatric mechanical support in ECMO. I'd like to thank Dr. Kreutzer and the committee for inviting me to speak today about the use of ECMO and durable mechanical support in early single ventricle patients. I have nothing to disclose. Today, we're going to discuss the surgical approach to ECMO and durable mechanical support in the early stage 1 and 2 palliation of the single ventricle. We'll also delve into the recent strategies that have improved the outcomes in this high-risk population, proving mechanical support is an important adjunct in the care of these patients. There are 4 general approaches to mechanical support in these patients. When a patient is expected to have reversible underlying pathology and recovery of cardiac function is anticipated, ECMO can be used as a bridge to decision or recovery. For patients with non-recoverable cardiac disease who are candidates for long-term support, ECMO can be used as a bridge to VAD support or as a bridge to cardiac transplantation in a select few patients. Lastly, ECMO can be used for pulmonary support in the patient where the primary challenge is respiratory. In the case of single ventricle patients, ECMO is often used in the short term for recovery in the immediate postoperative period, resuscitation after acute shunt failure, or pulmonary support. Rarely in a select few patients, it may be used as a bridge to transplant. Durable mechanical support is reserved for the failing single ventricle or single ventricle expected to have a long wait for transplant. So let's first focus on ECMO in this group. Stage 1 palliation in hypoplastic left heart syndrome in single ventricles can be accomplished in a variety of ways. The first 2 diagrams represent the Norwood operation with either a BTT shunt or an RVDPA conduit. The last is the hybrid procedure, most commonly reserved for higher risk patients that cannot undergo the Norwood procedure due to prematurity, size, anatomy, or comorbidities. Postoperative complications are many, but include myocardial ischemia or edema, pulmonary hypertension, or anatomic issues. In the setting of neonates with single ventricle palliation, ECMO can offer pre-op stabilization, a temporary rescue in those that fail to wean from bypass, aid in low cardiac output syndrome or refractory hypoxia, or those that have cardiac arrest. Overall, ECMO is used in 1.4 to 5% of neonatal cardiac cases, and according to the ELSO registry, 15 to 20% of patients undergoing stage 1 palliation require ECMO. The goal of postcardiotomy ECMO in these patients is to offer the failing myocardium or lung parenchyma a chance to recover while the body is supported with adequate perfusion and oxygenation. As you can imagine, this goal is very important when dealing with high-risk single ventricle patients. If ECMO is needed in the immediate post-op period, central cannulation is preferred. This involves cannulating the neo-aorta and the common atrium. Careful attention must be made to ensure the newly constructed aorta is not damaged. ECMO management is dependent on shunt type used at the stage of palliation, as flows will need to be adjusted accordingly. In a BTT shunt, they'll be run off of the systemic perfusion via the shunt to the lungs. In order to compensate for this, flow should be 150 to 200 cc's per kilo per minute. The other option is to place clips on the shunt. However, possible complications of this are injury to the shunt as well as possible thrombosis. In those patients that undergo an RVDPA conduit or SANO shunt, you want to ensure that there is flow via the conduit so it does not thrombose. Use of inotropes while on ECMO may be needed to promote contractility of the ventricle to prevent this. Once on, it's important to investigate early, usually in the cath lab, for possible anatomic or technical reasons for failure due to wean from ECMO. In patients that are interstage and may come in with either poor function from arch obstruction or hypoxia from shunt failure, a reduced sternotomy with central cannulation in the emergent setting is not an option. These patients will be peripherally cannulated. Again, flows and ECMO management will need to be adjusted based on the shunt type. And again, it's important to quickly investigate to find the reason for arrest, correct the cause, and separate from ECMO as soon as feasible. Following the hybrid procedure, cannulation can be either peripheral or central. If central cannulation is performed, the aortic cannula will need to be in the PDA without disrupting the stent or the pulmonary valve. If there is pulmonary insufficiency, the MPA may need to be tightly banded or snared, again without disrupting the stent to avoid distension of the ventricle. In both scenarios, ECMO flows must be treated like a patient with a BTT shunt, so flow should be 150 to 200 cc's per kilo per minute. Systemic perfusion can be challenging in this cohort due to the aortic arch. In many of these patients, the aortic arch is perfused via the ductal stent. Additionally, there is retrograde perfusion of the coronary arteries. This means that if the arch is not perfused well, there will be a risk of myocardial ischemia. Another scenario would be in the case of loose PA bands or a poorly positioned aortic cannula. This leads to excess runoff into the pulmonary circulation at the expense of the systemic circulation. In this situation, until the problem is remedied, ECMO flows must be higher to compensate for the runoff, and the bands must be tightened. So, how well do these patients do? This study is from the ELSO registry looking at 738 neonates from 2000 to 2009. 26% of all neonatal cardiac runs were single ventricle patients. 59% made from ECMO and 31% survived to discharge. Increased mortality was associated with longer ventilation days prior to ECMO, presence of lung injury, inability to wean from cardiopulmonary bypass, as well as longer runs. This is a look at the ELSO registry from 2002 to 2011 of patients undergoing the hybrid procedure that required ECMO. There were a total of 44 patients that required VA ECMO. 91% of those were for low cardiac output syndrome. 36% were cannulated peripherally, and 62% were centrally cannulated. 50% moved from ECMO, however, only 16% survived to discharge. This is a stark difference from the 31% survival rate of all neonates with hypoplastic left heart syndrome supported with ECMO. Here at Children's Hospital Pittsburgh, the use of ECMO has notably increased our survival to discharge. Here we are looking at our Norwood population separated by era. In the early era, we did not routinely use ECMO in the post-op period until we were peri-arrest or arresting. As time has gone on, we've learned that early initiation allows us to prevent the end organ dysfunction and the sequela of cardiac arrest. In the current era, we use ECMO in 53% of our Norwoods post-op. You can see as we changed our approach to ECMO in this population, our overall 30-day mortality decreased and our overall survival increased from 85% to 97%. Just looking at the ECMO population alone, the 30-day mortality in this group was 6% with a survival to discharge of 94% with 0% interstage mortality. This strategy has helped us decrease the overall morbidity that usually accompanies ECMO use. So let's move ahead to stage 2 palliation. Patients with cavopulmonary connections pose several challenges. These patients have often undergone several operations, have complex physiology, and often have significant clot burden or even vessel occlusion from prior lines or cath interventions. Additionally, there's always a need to address venous drainage from both cavas. Physiologically, there are barriers to ECMO optimization and even CPR. The cannulation of the bidirectional Glenn patient is particularly challenging because of the separation of the systemic venous drainage. This separation leads to difficulty maintaining adequate venous drainage and systemic perfusion. Cannulation may need to be tailored according to the cause of decompensation, and if the reason is primary respiratory secondary to infection, cannulation of only one of the cavas may be adequate. However, if there are elevated Glenn pressures, the superior cava will need to be drained in order to decompress the Glenn and cerebral venous system. Lastly, if it's due to poor function, both cavas will likely need to be cannulated to achieve adequate flows and avoid hypoxia. Cannulation immediately after surgery is usually central. This involves cannulating the aorta as well as the SVC and right atrium for drainage. The pros include having a fully saturated patient with decompression of the ventricle, allowing for better myocardial rest. The downsides are that you will be constrained by time due to an open chest, leaving the patient at risk for infection. Also, cannulation of the SVC may lead to SVC syndrome in the future, and the challenge of maintaining balance between systemic perfusion and venous drainage continues to exist. In patients further out from surgery, peripheral cannulation is favored. Again, the cause of decompensation will determine if one or both cavas will need to be cannulated. The pros are that these patients will have a closed chest and can tolerate a longer run if needed for respiratory diagnoses. If only the IVC is cannulated, you may be left with a desaturated systemic output. Additionally, cannulas in either cava pose potential injury to the cavopulmonary anastomosis, as well as potential for clot or thrombosis at the access points long term. ECMO support is difficult in this patient population because you need to balance the venous outflow to both decompress the cerebral circulation and provide adequate flows to support end organ perfusion. Early studies that included patients that were status approach stage 2 palliation and required ECMO showed very poor outcomes in the early era. However, more recent studies have showed more promising results. Mascio et al. Evaluated the peri-op use of mechanical support in pediatric heart surgery. In this study, the post-op use of mechanical support after the bidirectional Glenn was rare at 0.8%, but with a 56% mortality in those treated with ECMO compared to 1.6% in those not requiring ECMO. In perhaps the largest study to date, Jolly et al. Utilized the ELSO database to evaluate ECMO use in patients after the Glenn operation. In this study, 103 infants with Glenn physiology underwent ECMO cannulation. Of the original 103 that were cannulated, 68 were decannulated, and 42 patients ultimately survived to hospital discharge. Glenn survival to discharge after ECMO was 41%, which was notably higher than that for stage 1 at 31% and stage 3 palliation at 35%. The authors concluded that while the mortality does remain high for this patient population, it is lower than historical studies originally demonstrated and remains reasonable to consider in certain situations. So let's look at longer-term support in these patients. In spite of improving outcomes of neonatal palliation over the years, patients still often develop cardiac failure refractory to maximal medical management. Heart transplantation is accepted as the definitive therapy for failing single ventricle patients and can be speculated to be the 4th stage of single ventricle palliation. Needless to say, heart transplantation is a very scarce resource with far too few donor organs available to meet the need of all failing single ventricles and non-failing single ventricle patients. These patients often have high levels of pre-existing panel reactive antibodies, and these antibodies further shrink the eligible donor pool for these patients, thus increasing their waitlist time. Furthermore, the enthusiasm for transplanting failing single ventricle patients is decreased amongst surgeons because patients themselves are at increased risk as compared to the standard heart transplant waitlist patient. As a consequence, the use of mechanical support for failing single ventricle patients as a bridge to heart transplantation is being more widely used and perfected. VADs give us the ability to preserve end organ function and facilitate rehab. But as we talked about before, the single ventricle population, especially in the early stages, is more complex than in those with biventricular physiology. The supportive stage 1 single ventricle circulation is challenging due to multiple factors. These include small patient size, limited support options, immaturity of the coagulation system, and the nature of a parallel circulation with the nearly unavoidable imbalance between systemic cardiac output and pulmonary blood flow due to dropping pulmonary vascular resistance. Device options in this patient group in the first 6 months of life is limited to the Berlin X-Core, which is pulsatile, or the PD-Mag, which is centrifugal. For the most part, these pumps are used to support the systemic ventricle exclusively, with pulmonary blood flow supported by the BTT shunt, RVDPA conduit or cavo-pulmonary connection. This is a look at the most recent PD-Max registry. Single ventricle heart disease comprised 66% of total VAD implants for congenital heart disease patients. While the VAD outcomes for stage 3 single ventricle cohort emerged similar to those for the biventriculars, the stage 1 and stage 2 single ventricle cohorts had significantly worse prognosis, with a greater than 40% mortality and less than 50% survival on VAD by the 3-month mark in both. Anatomic and physiologic complexity, chronic circulatory abnormalities, previous surgery, and related end organ dysfunction contribute to the higher morbidity and mortality in these patients. While the aforementioned multi-institutional studies cast a gloomy look for stage 1 single ventricle VAD support, single-center reports are more encouraging. 2 major VAD pathways have developed as such: salvage or elective. Salvage occurs after the initial palliation as a rescue, and elective occurs prior to palliation as a bridge to transplant. This would be in patients whose cardiac anatomy precludes standard surgical management, such as PAIVS with RV-dependent coronary circulation, or hypoplastic left heart syndrome with coronary ischemia secondary to coronary fistulas. These patients may have the benefit of being placed on VAD support in an organized fashion, possibly resulting in better outcomes secondary to less end organ failure. In the PD-Max stage 1 single ventricle cohort, The majority of patients were in the salvage situation. 91% received VAD after failed cardiac operations, and 59% were INTERMAX 1 or critically ill. The advantage of this elective strategy is demonstrated in a recent report by the University of Florida group that described 9 patients with stage 1 physiology who were supported with the Berlin. 2/3 had no prior surgeries before the VAD implant, and 67% of patients made it to transplant. This is more promising than the less than 50% survival in the multi-center registry data. One of these patients even initially underwent NORD palliation, required ECMO, was bridged to transplant on a Berlin, and successfully discharged home. Some centers have also been successful with the salvage tract patients. The group from St. Louis reported 7 patients all having some form of palliation, 3 of which were on ECMO that were then converted to VADs. 5 of the 7 patients, or 71%, survived to recovery or transplant. Overall, these encouraging single-center experiences would suggest that the key to success in these tenuous patients may lie in either timing or selection, or a combination of both. Cannulation involves a cannula in the common atrium and outflow cannula on the neo-aorta. At this point, the VAD must supply both systemic and pulmonary flow, so double the normal cardiac index is required. The excess flow can make management in patients with AV valve regurg or increase systemic venous pressure more difficult. As we saw earlier in the PDMAX study, salvage VAD outcomes tend to be dismal within the first 12 months of life. The University of Florida group has attempted to identify the minority of neonates with functional univentricular circulation who are high risk prior to initiating stage palliation and stabilize them with a preemptive single ventricle VAD. As discussed before, elective VADs are usually placed in the patient where surgical palliation is prohibitive due to anatomy, cardiogenic shock, and organ failure or severe AV valve regurgitation. In this group, bilateral PA bands are placed with expandable Gore-Tex so the bands can be ballooned in the cath lab as the patient grows. An 8mm graft is sewn to the pulmonary artery. At that time, through this graft, a PDA stent is delivered. This gives a larger delivery runway and avoids potential vessel injury. To avoid the possibility of reverse coarctation, a 4mm shunt is placed from the outflow graft to the innominate artery, and then the aortic cannula is sewn to the outflow graft. The atrial cannula is placed in the common atrium. VAD flows are 4 to 5 liters per minute per meter squared, and bivalrudin and antiplatelets are used for anticoagulation. Depending on the type of palliation performed, the support type is tailored to the specific anatomy. These are illustrations of the type of elective single ventricle VADs performed for the patients at the University of Florida. Their series included 9 patients, 3 of which were post-palliation. The total survival in the cohort was 66%. The survival to discharge post-transplant was 83% in patients bridged to transplant and 33% in patients bridged to decision. Survival to discharge post-transplant was comparable among patients who were post-primary surgery and primary salvage. They felt that the reasons for improved survival in this cohort is multifactorial. Pre-palliation selection and implantation of these patients prevents end organ insult that is likely one of the most important factors. Additionally, adequate decompression via an atrial cannula as well as aggressive medical therapy and use of bivalve for anticoagulation contributed to overall improved outcomes. A novel strategy was recently described involving transitioning to the univentricular heart to biventricular configuration. This came about due to the dismal survival initially reported in single ventricle VADs with high mortality rates due to stroke, respiratory failure, infection, and difficulty balancing the systemic and pulmonary circulation. This procedure can be done in either the elective or salvage situation. The details are listed here, but the idea being that supporting the heart in the biventricular configuration may decrease the morbidity and mortality to that of age-matched children with biventricular circulation supported with a VAD. The results of this procedure need to be seen with more implementation in the future. This recent report from the Action Network shows promise for these new approaches in this cohort. 30 patients from 32 centers were included from 2018 to 2020. The median age was 0.9 months with a median weight of 3.7 kilos. Pre-implant illness severity was high, as seen here, and the median duration of support was 56 days. Overall, 63% of patients were successfully transplanted, and there was 37% mortality. While still high, this is a marked improvement compared with outcomes less than even a decade ago. Just as in stage 1 patients, stage 2 patients present a unique challenge to VADS as seen here. Chronic hypoxia with the resultant polycythemia jeopardizes the hematologic management. Due to the potential for inadequate mixing and streaming, the location of the inflow cannon significantly could also affect the ability to maintain systemic saturations. Another issue specific to the gland circulation is the pressure differential between the upper and lower body systemic venous systems, with the pulmonary vascular resistance being additive in series with the systemic vascular resistance of the upper body. Because of the direct decompressive effect of the systemic VAD is limited only to the systemic venous system in the lower body, the pressure differential will be further exaggerated if the systemic VAD support is provided in failing gland physiology, especially if the PVR is high. Such an uneven decompression would result in worsening hypoxia due to the development of veno-venous collaterals from the upper to lower systemic venous system. Currently, the reported mortality in this population is 52%, with no survivors less than 7 months old. As we talked about earlier, ECMO use in gland physiology offers disappointing outcomes with high rates of morbidity and mortality. Cannulation can be challenging given the dichotomous cavas, and flows must account for the presence of AP collaterals. In both cases, cannulation involves the ascending aorta as the outflow, and inflow can either be the ventricle or the atrium. Given the likely AP collateral formation, generous VAD flows are required, thus leading to hypoxia and the possible need for an oxygenator. Success with a VAD at this stage is about anatomy, physiology, clinical status, and age of the patient. If a patient has undergone a glen and had a prior cardiac cath confirming the lack of elevated PVR, but continues to have poor cardiac output, that patient should be able to have their cardiac output augmented with a VAD to recovery or transplant. If there's elevated PVR and evidence of failing glen physiology in addition to poor cardiac output, it's likely the patient would benefit from a glen takedown and VAD if needed for improved cardiac output. Similarly, if an older patient has adequate PVR for Fontan but poor cardiac output, the patient may benefit from progression to Fontan with the possibility of VAD. This approach of upgrading or downgrading stages removes the unwanted hypoxia that accompanies augmented cardiac output in glen patients with VADs. This is a look at the latest outcomes of post-stage 2 palliation single ventricle VADs as reported by the Action Network. Patients with failed stage 2 physiology have high illness severity prior to VAD implantation. Although adverse events were common, this strategy was a viable bridge to heart transplant. As you can see, 2 of the 13 patients underwent Fontan completion and 1 glen takedown to a BTT shunt. The vast majority of those transplanted survived to 1 year post-transplant. 77% had a positive outcome. This is better than the 52% mortality previously reported in PDMAX. To illustrate the improvement in outcomes in both stage 1 and stage 2 patients, here's a look at the St. Louis group. From 2012 to 2020, they had 18 patients with single ventricle physiology that required VAD support. 9 patients needed ECMO prior to VAD, 7 or 39% were transplanted, 2 or 11% recovered, and 9 or 50% died prior to discharge. 2 of these were after transplant, 2 after explantation of the VAD, and 5 were actually redirection of care secondary to progressive pulmonary venous occlusive disease. 9 or 50% of the cohort were alive at median 1-year follow-up. Their experience shows that single ventricle children, including newborns, can be successfully bridged to desired endpoints with the proper patient selection and using specific cannulation strategies. So to sum all of this up, basically this is an extremely high-risk group of patients with inherent morbidity. The risk profile for adverse outcomes and mortality is high. Whichever mechanism of support is chosen must match the patient's size, anatomy, and physiology. Timing and patient selection is key to success. ECMO is an invaluable tool for post-cardiotomy hemodynamic compromise or hypoxia after stage 1 and 2 palliation. Timely utilization of ECMO prior to permanent or debilitating organ dysfunction is important. Investigation of all possible reversible causes for cardiac dysfunction early during the ECMO run allows for separation from ECMO in a timely manner while minimizing complications and increasing survival. The field of mechanical support in these patients is actively evolving. The combination of both refinement in cannulation technique and newer anticoagulation therapies has led to recent success. Strict patient selection, early initiation, and tailoring each approach to individual patients is of utmost importance to the continued improvement in outcomes and survival in this extremely challenging population. Ultimately, collaborative learning amongst centers will likely allow us to further improve outcomes and survival that will be seen across all of these challenging patients. All right, so that's it. Thank you again for inviting me to participate today. I apologize for not being there in person, but here's my email. If anyone should have any questions, please feel free to reach out. Thanks again.